has the usual cardiac risk factors and came in with CKD state. His creatinine in Canadian units is 351, so his creatinine is roughly 3.3 here in India or in the United States, with a GFR of less than 15. On the usual medical therapy, admitted with abdominal pain that was found to be ischemic in origin from a squeezed bowel. As a result of an inguinal hernia, they reduced that. He had acute decompensated heart failure, and then while in hospital, once he had recompensated, was getting chest discomfort, doing very minimal activity. His echo demonstrated a left ventricular ejection fraction of 12%. His anterior wall was thinned and akinetic. There was moderate RV dysfunction, mild AI, moderate MR that was posteriorly directed, and an RVSP of 63, with a viability PET done that demonstrated viability in the inferior wall and the infralateral wall, but no viability throughout the anterior segments. And so these are the angiograms. So you'll see on the right was our target, which is the RCA. Okay. And oops. I'm trying to get it to show you then. This is your left system. Oops. It's always challenging with cases in boxes, right? So that shows you your left system. So this entire segment of the anterior wall is dead. The circ was alive but unobstructed. The inferior wall was ischemic and viable. There were retrograde septals into a PDA that gave an RPL system. And there was a proximal diagonal branch in a patient with an extremely poor left ventricular ejection fraction and the presence of pulmonary hypertension with an RVSP of 63 and a GFR of less than 15. So this was the hemodynamic support algorithm that we wrote for the Asia-Pacific region a few years ago. And so in this gentleman, we took the time to define what his needs would be for hemodynamic support, whether or not we really needed this or not. So just calculating that together, his LVEF was 12, so he got 2 points there. His systolic blood pressure was actually about 100. As you'll see during the case, it gets pretty soft as soon as he gets any sort of medications. His cardiac index was less than 2, so he got another point there. He has renal dysfunction, that's 4. His age was, I think, in his 76, so he got 1 point there. So that's 5 already. He has neither severe AS nor severe MR, so he didn't get any points there. He was a surgical turn down, so that's 6. And then he's got a large area of myocardium at risk, that's 7. And he's got a complex CTO with a retrograde approach to the last remaining viable segment. So he was well into the strongly considered hemodynamic support range. I think objectively, the patient had very little reserve. We were going to obstruct his main retrograde conduit, and he had a long segment of RCA that was going to need to be addressed. We thought about doing this antegrade, but as you'll remember, we recognize that losing side branches in the setting of CTO-PCI is really costly. And his RV function was okay, and this was the main RV branch supplying that territory. We really didn't want to lose that, and so going antegrade at this point was not our primary plan. I don't know if, Arun, you have any comments about that. Try that one on the table there. Yeah, there we go.
This is a really challenging case, to state the obvious. I think you would be out of your mind to try and not use MCS for this case. I mean, pretty much meets all criteria, right? All the check boxes. The other reason was like this guy's one step away from dialysis. So one of the things, and so, when you're going through the whole decision-making algorithm, using that retrograde is going to really minimize your need for contrast.
That's right.
Besides all the points that you said, I mean, I would preferentially, I mean, you would work antegrade, obviously, but the ultimate strategy is going to be a retrograde approach for this.
Correct. So our plan here was retrograde CTO-PCI, primarily using the septal as a retrograde conduit, using the diagonal as a marker for where the septal entry was, and to do this with an ultra-low contrast approach. Our contrast target was less than 10 cc's for the entire case. So we didn't take any antegrade pictures to start. We used the previous pictures from these angiograms, which were done weeks prior, to define what our targets would be. This is the CHIP score, the BSIS CHIP score that was published some years ago that defines sort of the the upfront risk of in-hospital MACE in patients like this, and this gentleman's BCIS CHIP score was 9, so it gave him an in-hospital MACE rate of about 10%. So I'll just move forward here. This is the access for the Impella that we used. It's a single access approach. And this has some ups and some downs, right? So that's the 14 French Impella sheath, through which we use a micropuncture sheath to create a hole at either the 2 o'clock or the 10 o'clock position, put a micropuncture sheath in, and then put an 035 wire in, and then along that, you'll see this 7 French Trumeau destination sheath that we placed on that wire so that it goes directly into the Impella sheath, right next to the Impella, and allows you to limit your procedure to this access point plus one additional one. This guy didn't have much in the way of radial, so we ended up going bifemoral for this case. So you'll see that there's no bleeding with the wire out, right? And when you're putting this in, you have to put a little bit of elbow grease on it, but then once it goes in very nicely. And you've got about a 10 centimeter segment to the end of the sheath that is not hydrophilically coated that sits outside the Impella sheath. This unfortunately means you lose a little bit of guide catheter room though, and as you'll see that becomes relevant because it's actually very hard to get adequate support when you have a guide catheter that's even on the borderline short range when you're in this sort of a situation because you're losing a lot of length from the tip. And that's something that we tend to have to think about when we do these types of cases. So this is into the case now where we've got a wire in the diagonal branch to tell us approximately where the septal is. And this septal, as you can see, was retroflexed. It was very difficult to get into, and because we weren't able to take any pictures, this took some time. And ultimately what we required was a Supercross 120 catheter, right? An angled microcatheter to be able to direct our wire tip retrograde into this retroflex, down this retroflex septal, but across that very noxious sort of 290-degree bends. And that was arguably one of the most challenging things to do. And as you can see, it was very difficult to direct the wire. And so from a sort of access point, Arun, do you have any particular preferences of wires that you use to get into these retroflex septals that are challenging, particularly when you can't take pictures?
I like the cyan blacks for this. I get good torque control. I generally prefer the hydrophilic polymer jacketed ones. And truthfully, I think we underuse Supercross. The traditional thing before it came about was you would use dual lumen catheters and try and do this. It's actually it's a lot easier for you to at least get access, get enough purchase, and then swap it out. So I tend to use cyan blacks. Do you have a choice of
so my usual one here is a cyan black. The only thing that's worth mentioning is the construction of a whisper wire is a parabolic grind on the curve, on the core, where the core is thicker and more supportive towards the back. And it parabolically grinds down towards the tip. As a result, the further back on the wire you go, the less the wire will flex. At the tip of the wire, it's particularly well suited to go around nasty curves, though you want to switch it out shortly thereafter. I think that was my go-to in these situations prior to the Xi'an Black. Now the Xi'an Black with its Act 1 core polymer jacket is so good that that's usually what we end up using. And so, as you can see here, we've sort of entered the septal that we expect to be able to access, and now we'll switch it around and bring your standard antegrade, standard retrograde 150 centimeter microcatheter in. This was a 150 Turnpike LP, and you can see the various curves being navigated. So bring that in, and then, and as you can see, this was a live case that I did. So it was a little bit of time pressure on this type of a case because you can't take pictures, and so a large part of the hemodynamic implant and such was done prior to going on camera because it's awfully difficult. What you'll see is I have a cardiac anesthesiologist helping me with this case, and so you'll see the vitals up on the screen. So you can see that we're monitoring the PA pressure as we go, and even on a hemodynamic support device at full flow, his PA systolic pressure is 63 on a PAD of 24 with a CVP of 8. And he's on sevoflurane at this point. He's on an inhaled anesthetic, which dramatically vasodilates. Despite that, he has very little reserve. So it sort of speaks to how these types of cases really do take a village, where trying to bang in with a single operator to try to just get the case done, I think is a good way to get your patient in trouble. So here's your sort of retrograde It doesn't take much time, mostly a septal approach. I think I was pretty comfortable with where I was as I went down, and as you'll see, there you go, you're up into the RCA. It really doesn't take very much time to do that. But this is where the fun in this case started, where it looked like the septal segment was quite big, and getting the microcatheter across the septal was easy. It was what do you do after that's done, because that was the most challenging part. Once we got into the angulations that you were seeing, there was an awful lot of calcium down there, and so tracking the retrograde microcatheter became a problem. And if you look at the retrograde guide catheter, you'll see that it's pushing out, and that's because it's through the single access, right? It's through the single access. I've got the antegrade microcatheter completely disengaged, and that's because I do not want to encumber flow into that antegrade RV marginal branch, right? This is one of those reducing hemodynamic load strategies. Keep your guides disengaged if you don't need them, because all you're doing is introducing a fixed stenosis during that time. And so this was quite a challenge, getting this microcatheter down. And ultimately what we chose to do was, you'll see, we'll take that diagonal wire, push it down, and we actually put an anchor balloon into that diagonal, which is what allowed us to push this forward. But that's not without its jeopardy. And what we found was, as you'll see, when we put the retrograde, or when we put that anchor balloon up, we started getting a fair amount of pressure dampening and reductions in systolic pressure with reductions in pulsatility. And that just sort of speaks to how dependent this gentleman was on every single vessel that was open.
So could I ask you just a quick question as you're showing that? So typically, right, I mean, given his precarious hemodynamic status, yes, the patient was on an impeller. So, and you knew this was a septal, and you're pretty sure there was not an epicardial course. I'm assuming it's a turnpike?
Yeah, it's a turnpike LP.
LP, right? Yeah. What is your threshold? So I'm sure you were thinking about the whole algorithm, right? Hey, wire across, my microcatheter won't cross the collateral. So something that both of us know that we often do is dilate with a super low profile balloon.
Yeah.
Why did you prefer to put in an anchor in the diagonal rather than just take this out, balloon, and then go back in?
To tell you the truth, it was at the time because I was already down with a microcatheter and I was in a live case, so I didn't want to go back and forth. Having said that, that's an excellent strategy, and I do it all the time. Right? That I think, arguably speaking, in this type of a patient, I would probably do that before I would use an anchor in regular circumstances. Right? And I think eventually we did end up doing that. Yeah, we did end up doing that. So as you'll see, we come to a straight RA view because it's really easy to see exactly where the microcatheter is, where you can sort of lose it in some of the other projections. And you'll see that the retrograde guide is pushing out yet again. So this is when we started getting fed up with it and started putting anchor balloons down to try to get everything going because it was just so difficult. But what we did was pull the diagonal wire back, and we decided that we would try to put an anchor in. And initially we had considered anchoring in the circumflex. The challenge is that this was a relatively normal vessel. And the jeopardy is that your anchor balloon will dissect your normal vessel. And in this type of a patient with absolutely no reserve, we were increasingly uncomfortable doing that. So ultimately what we ended up doing, as you'll see, is I'm just going to push this forward, is putting the anchor balloon up initially in the diag, and then eventually we actually pulled that balloon down into the, pulled that wire down into the LAD, which was a largely non-viable territory. So we weren't really worried about hemodynamically encumbering the patient, and then put our anchor balloon in there. And that's where we ended up anchoring everything to be able to get the microcatheter across. You know, and admittedly, looking at this, Arun, would you have worried that microcatheter transit would have been a challenge? No, right? No. So I didn't think that either. So this just speaks to the importance of how your retrograde guide actually should fit.
I was just going to
This
say,
was all a guide support problem.
Guide support issue here. Yeah. But guys, I do want you to pay attention in particular to how Sanjog's going to manipulate this the torque and the transmission with one hand and with the other. I think India, predominantly the microcatheter that's used is fine cross, and that's more of a push thing. People don't necessarily torque it. So when you're using Corsair or turnpikes, the way Sanjog's kind of using it is a much more efficient way of transmitting than just push the microcatheter. I know it's kind of basic, but I think that's an important point to note.
Yeah, the other thing is that this is a single operator maneuver, right? There are some people who will hold the wire at the back, and what that invariably ends up doing is just pulling your wire back, because you need the tactile feedback and you need the movement feedback and control of both segments as you transit the microcatheter down, because it will pull back on you as you get any sort of resistance. So this is that diagonal wire down the LAD now into that non-viable territory where I was a lot less worried about an encumbering patient hemodynamically. And here's where we ended up stuffing an anchor balloon down there, and everything started to move forward. Right? So there's our balloon, and we push that across into the mid-LAD, and initially, I guess we anchored in the diag, and then later on, you'll see that it anchors into the LAD there.
If you had to do this case all over again, would you flip the guides? Would you use your left femoral?
Yeah. No, so the reason why, this is a good question. The reason why I went this way is because I did not have the right guide to reach the RCA through that single access. That was the problem, right? The problem was actually, I remember this was at 6 o'clock, 7 o'clock in the morning on a Saturday for a live case. It was challenging, and we, of course, were super lucky in that the one guide that we needed for this had been used the day before, and we just didn't have it in the lab. So it was a real pain. So, as you can see, we've sort of transited our microcatheter, and there's our retrograde Xi'an black. And interestingly, it's sort of flipping back and forth. You'll see that with the ability of, or with the microcatheter in that position, it's actually really easy to manipulate that retrograde wire. And the nice thing is here that over the course of this case, so far, there has been 0 cc's of contrast used. Right? There's just no need for it. You have wire structures with the wires in front of you. You know exactly where you are. You have the previous pictures, and you have hemodynamic stability, relatively speaking. So you just match the views, and off you go. So this is in an RAO view. And you see now with that anchor balloon present, the guide catheter is not the happiest position. But there's my retrograde wire. And it's always nice when you get lucky. Just keeping an eye on the time, which is why I'm advancing us forward.
Take all the time that you need. My case is a short one.
So this is just a Xi'an black, and there we go, we're out, right? So there is no antegrade guide in the RCA at this point, because again, we were trying to reduce the hemodynamic load, and when we would put the antegrade guide into the RCA, his pressure would start to drop. I think Akiko might or might not remember the live case at CTO Plus that I did there, where we had the same problem, where we touched the RCA with the antegrade guide. You'll remember that as well, actually, right? Where we basically lost pulsatility completely. My case had a left main LAD, occluded circ, diseased right with an EF of less than 20 in a post-bypass patient, and we just put the antegrade guide in and his pressure would tank. So we had to keep it out. So as you can see, right at the top of the screen, just under the word Jan, that's where my antegrade guide has been sitting the whole case. So we'll bring that forward now with a J-wire, try to engage it, and then try to wire out retrograde. And this you do have to be a little bit careful of when you have an impella in the aorta, because as the antegrade guide comes down, you can hook the end of the impella, and that can knock it out of place. So you do have to be at least reasonably aware where your wire is going, and try to make sure that the wire doesn't actually wrap the impella, because if it does, then you will create forces on the hemodynamic support device that will get in your way, and that you don't want to do. And so my usual setup for the antegrade is very similar to what you saw with Ashish a few moments ago, where I'll put an antegrade trap liner in. That's also been recently introduced into India. Has anybody in the crowd had experience with a trap liner? Here? So it's effectively the same as the guideliner, only it has a trapping balloon on the shaft, right? I know, and I think you probably launched that device here, did you not? Yeah, this is a very useful device. It was invented by Chris Buller, whom I had the privilege of training with as a fellow. He's now the chief medical officer of Telflex, but it was a very simple invention, the idea of putting a trap balloon that we all know how to use just on the shaft of the guideliner, so you don't have to keep transiting in and out with a trap balloon, and extremely well to be able to trap and exchange microcatheters and other equipment without losing wire position. So here I have this antegrade wire, or the antegrade microcatheter engaged, and the idea will be just to create a glove into which we can throw the retrograde externalized wire. Right, and that's effectively what we're doing here. So I just put the antegrade microcatheter down, pulled the retrograde wire back, which is currently out in the aorta. We'll pull it back, and then we'll just throw it into the antegrade guide extension catheter. It allows us to get the whole deal done. Now, unfortunately, in this situation, we had externalized and actually pinned the retrograde wire inside the trap liner. So we had a really solid system, but surprisingly, we were unable to breach the distal cap of the microcatheter. We tried and tried and tried, and I actually took this microcatheter out and replaced it with a new one, and it still did not want to transit, which is why at the bottom you see there, sort of failed microcatheter transit. This is one of my colleagues, Dr. Vlad Javik, who's a well-known operator, I think, in India as well. He's done a lot of bifurcation training here for some of the people here. And this is the benefit of having two operators in some of these cases where, you know, your hands get tired after a while, right? So you swap out with somebody and allow them to try. And unfortunately, Vlad also tried to get this microcatheter up. And as you'll see, we weren't having much success, even though there is an anchor balloon up in the LAD. Right? So really struggling with a variety of different strategies. So Arun, what's your strategy in these sort of situations, recognizing that you're trying to preserve the RV marginal branch that's basically coming off right there?
I mean, you already have the wire in you have the externalized wire. Just come antegrade. I mean, just.
Yeah. So what you just heard was you've got a retrograde externalized wire. Ideally speaking, you'll be able to transit your retrograde microcatheter up. The challenge is if you're repeatedly having difficulties doing that, you have the perfect marker and a track formed to flip antegrade and try to just use the retrograde kit as a guide to get your antegrade wire down. There is jeopardy in that you don't, Kiko was there when the CTOs were collected for that paper that defined your in and out, so your true, false, true, a quarter of the time when you think you've gone true to true, right? So recognizing that there is that danger of going across the sub-interface with that RV branch that we've been trying so hard to preserve, we have a reasonable guide here and we know exactly where to go. So as long as that wire can transit through effectively the same segment, your risks of that are going to be relatively low. And that's exactly what we ended up doing, where we ended up bringing this antegrade wire. And that's a Raider wire, right? So core to tip, polymer jacketed, mid fours, I believe, tip strength, and directable. The core on a Raider goes right to the tip, so it's a slightly larger knuckle than you will get with a Pilot 200, much larger than you would get with a Mongo if that's what you chose to use, but it does a very nice job of antegrade, as you'll see. Right, and so here we brought a turnpike spiral down antegrade so that we were fairly close to the retrograde microcatheter, and then it was just a matter of directing the antegrade wire down the pathway that we were trying to select for it. It's with a lot of care, trying to make sure that it didn't buckle and that you're not pushing yourself to go into the subintimal space, because that's going to cost us. And that's effectively what we ended up doing, where we wired just past the retrograde microcatheter, as you'll see in a second. And there's your Raider wire starting to get close to the the retrograde microcatheter. And here it comes going past. And are you a torquer guy? Do you usually use torquers with polymer jacketed wires?
Polymer jacketed, generally not, but
Generally
I sometimes
not,
do it, sometimes
yeah.
I don't.
It's sort of one of those things where, like, I typically don't, unless I'm in one of these situations where you really don't have a lot of room for error, and then you're using more than just the properties of the wire to be able to get the wire down. So here is that bit. And it's a lot of disease there, right? So the wire wants to take a variety of different pathways, which I was not particularly happy with. And then you see the wire now start to enter the space that's parallel to that retrograde microcatheter. There's your wire going down. And this one just sort of flew across. And so now this became an exercise in doing IVUS-guided PCI, right? There was nothing all that complicated about this. And once we had an antegrade wire down, we IVUSed and confirmed that we were antegrade. And we're very aggressive about getting the retrograde gear out because, once again, we wanted to reduce that hemodynamic load. As you can see, the patient's PA pressures are still pretty high. They're a little bit lower. And it's, a lot of times doing these long cases, you think that the PA pressures are coming down. That's a good thing. It's actually not necessarily a good thing. It just means the patient's getting a SIRS response and getting vasoplegic, and that's why your pressures are coming down. And usually the hallmark of that is that the CVP starts to come down with it. The other differential that that one always wants to consider when an Impella is in place is that you're bleeding. And if you're bleeding, you do get into a lot of trouble. Your PA pressures will come down, but so will your systemic pressures. And here we were encouraged because we weren't on a ton of vasopressor support, and our systemic pressures were about the same, with a heart rate that was about the same as throughout the case. So, just tracking that forward for you. At this point, we had done the IVUS. We did some ballooning. And I'll show you the IVUS towards the end, unfortunately, because of just how the video did. And there isn't a whole lot of magic here at this part. It's just simple IVUS-guided PCI. You see that the technique that we used to define the ostium, which we needed to stent, was a cusp wire and a fluoroscopic co-registration of the IVUS lens, which I'll show you towards the end. And every so often we'll clear the guides with saline to make sure that as there's not a lot of back and forth, that we're not allowing clots to form within the guide. There's your sort of cusp wire, post-dilate. And then when we did the IVUS, we saw that distally we had a good amount of plaque. We did not want to stent that distal edge. And so what we actually ended up doing was choosing to put in a drug-coated balloon distally and using the IVUS to size it. The EEL to EEL diameter was just over 3, so we actually sized down a little bit with our DCB because we did not want to run the risk of dissecting the distal edge, recognizing that with DCBs, type A, type B dissections tend to heal larger than with a non-dissected vessel. We just couldn't use that much contrast, so we're just not willing to do that. And so the only picture of the case you're about to see, which is after everything has been fixed and reconstructed, and that is here.
Nice.
And that was your
Strong
final.
word.
That was your final result, and the total contrast used for the case was just under 10 cc's. It was 6 cc's, and it was that final picture, right? And I think I gave him another. I don't know about you, but I gave him, because I did the relations for anchor balloons, I gave him another 3 cc's to look at the left system to make sure that there were no injuries in the left system. And I have a Kiko here, so I would be remiss not to show the IVUS. So this was after the case was done, as we were presenting the final results to the group. This was the IVUS. Sorry, Kiko, I'm going to show you the final edge there. I don't know if it got edited, but there. So this is the distal vessel. This was all the DC bead segment. Right here, this was all DCB. And you can see that there was no substantial injury there. It was actually a really nice DCB result. It was very circular, very well behaved. And you'll see that the stent, this is the stent distal edge. And these were a bunch of synergy stents that we put in that were conservatively sized distally, but then we expanded proximally to a reasonably large size. You can see proximally there were a little bit undercooked, so we did make that bigger before we ended the case. Right there. And this was just to show the final result. And so that was our ultra low contrast retrograde CT.